Welcome to the Deep Dive. We're here to extract the key knowledge nuggets from your sources. Today we're taking that deep dive into, well, the pretty complex world of cholangiocarcinoma.
Yeah, it's a challenging one. It's the second most common hepatobiliary malignancy, and it's incredibly varied in how it presents and behaves. So for you, the radiologist, getting that detection, characterization, staging, and crucially, the resectability assessment right, that's paramount.
Absolutely. We've got a packed report today looking at ultrasound, CT, MRI, PET findings. Our mission really is to unpack those key radiological features. We want to help you understand the unique strengths, but also the limitations, of each modality. The goal is a more adaptive diagnostic approach, moving beyond just picking boxes on a checklist. Okay, so off for the first look is ultrasound, right? Accessible, cost-effective, usually flag things like biliary tree dilation. But how much detail can we really get for a specific diagnosis there?
Well, with standard B mode, intrahepatic cholangiocarcinoma, ICC, if it's small, say under 3 centimeters, it's usually hyperzoochoic. Larger ones, though, they can look hyperechoic or even mixed. And one specific sign to really look for, a key differentiator for ICC, is capsular retraction.
Okay, that helps narrow down. But you mentioned contrast-enhanced ultrasound, CEUS. How does that really boost what ultrasound can do?
CEUS is where it gets interesting. It typically shows this peripheral arterial rim enhancement, and then importantly, it's followed by hypovascularity in the portal and late phases. And the key thing really is the rapid washout. Often happens within 60 seconds, that timing. It's a major differentiator from HCC, hepatocellular carcinoma, especially in non-cirrhotic livers. We're talking high effectiveness, 86.7% sensitivity, 95.8% specificity.
Wow, so it really elevates US.
Exactly. Turns it into a powerful, non-ionizing problem solver, despite conventional US having limits for small lesions or in cirrhosis.
Okay, so after ultrasound, where does CT, computed tomography, fit into the picture, particularly for staging?
Right. CT is, widely seen as a cornerstone for initial detection and staging. Multi-phase protocols are crucial, especially getting that delayed phase. For the mass-forming type of ICC, the classic look is a hypoattenuated mass on the unenhanced scan. Then, with contrast, it develops this irregular peripheral arterial enhancement that's followed by a gradual centripetal filling and delayed enhancement centrally.
And that delayed enhancement, that tells us something specific.
It does. That central delayed enhancement correlates directly with the fibrous stroma within the tumor. It reflects the underlying biology.
That's fascinating. But what about those periductal infiltrating types? They sound trickier. How does CT handle those?
They are tricky, yeah. They often just look like subtle strictures. Malignant ones, though, tend to be longer, think 18 to 22 millimeters or more, and have a thicker wall, usually over 2 millimeters. They often show hyperenhancement in the arterial or portal phase too. So CT is great for spatial resolution, assessing vascular involvement, resectability, but it can struggle a bit with precise longitudinal invasion along the bile duct itself.
Which naturally leads us to MRI. You hear it's often considered superior for soft tissue contrast. How does MRI give us those deeper insights?
MRI often is superior, yes, mainly because of that excellent soft tissue contrast and its multi-parametric capabilities. So, mass-forming ICC. Typically slightly low signal on T1 weighted images, slightly high on T2. Add contrast, and you see that prominent peripheral rim enhancement, which then progresses centrally. And in the hepatobiliary phase, most look hypointense, often with a very distinct target appearance, which is strongly linked to that central stromal fibrosis again.
Okay, and for tissue characterization, which is so vital for us radiologists, what about diffusion-weighted imaging, DWI? How does that act like a specific fingerprint here?
DWI is absolutely critical. A good chunk of ICCs show a characteristic target-like diffusion restriction. This isn't just some minor finding. It's highly valuable for telling them apart from HCC. And we can even go further. Quantitative ADC values, the apparent diffusion coefficient, can actually help predict time to recurrence and overall survival.
Really useful prognostic information then.
Definitely. So MRI's strengths, no radiation, top-notch soft tissue detail, functional assessment make it invaluable for surgical planning, especially pinning down subtle ductal involvement. Of course, you have to watch for motion artifacts, and hepatobiliary agents can be tricky in patients with closed faces.
Right, always trade-offs. Okay, finally, let's talk PTCT, particularly with 18F-FDG. How does this modality change the game for staging, maybe finding things others miss?
PPCT really shifts the focus. It's less about characterizing the primary tumor and more about staging specifically, looking for distant metastasis and assessing nodal status. Cholangiocarcinoma typically shows high FDG uptake, which helps distinguish it clearly from most benign lesions. And its sensitivity for finding involved regional lymph nodes, around 74.5%, is actually higher than conventional CT or MRI alone.
That whole body view must be a major advantage then. How often does it actually change the treating plan by finding those hidden metastases?
Oh, it's significant, very significant. That capability finds occult metastases often enough to change the treatment strategy for, well, up to 30% of patients. It's a real game changer for management.
But it's not perfect, I assume.
No, definitely not. You need to be aware of limitations. Mucinous types of CCA can sometimes give false negatives because they have lower metabolic activity, and its spatial resolution isn't great, so it's less effective for precisely locating very small primary lesions.
So pulling this all together from our deep dive today,
Yeah.
what's the main message for you, the radiologist listening?
I think the key takeaway is that evaluating cholangiocarcinoma demands a really sophisticated multimodal approach. There's no single silver bullet. Each modality, US, CEUS, CT, MRI, PTCT, they all bring something unique to the table. They provide complementary information, compensating for each other's weaknesses. Your role as the expert radiologist is absolutely critical in synthesizing all this diverse data.
So, for you listening, the journey through CCA imaging isn't just about spotting a mass. It's about dynamically interpreting its biological fingerprint using all these tools. The real question is, how will integrating these detailed multimodal insights empower you to provide the most precise understanding